Hello and welcome to today's Center for Healthcare Strategies webinar on agency consent, part of the ongoing psychotropic medications in foster care exploring the issues webinar. To eliminate background noise, phone lines are being muted during today's presentation. There will be 3 question and answer sessions held during today's event, and instructions for participation are on the screen at this time. If you experience technical difficulties today, you may dial 1-866-229-3239 for assistance. Today's event will be recorded. Slides and a video archive will be available on our SharePoint website in the next week. At the completion of the webinar, we ask that you complete a very brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope you are able to complete the survey. I will now turn the webinar over to Kamala Allen, Director, Child Health Quality at the Center for Healthcare Strategies.
Thank you, Travis. It's my pleasure to welcome our participants to today's webinar. Our participants include 2 very special groups of individuals across the states. We have our 6 psychotropic medication quality improvement collaborative states on the line with us today. And we also have several states representing our psychotropic medication virtual learning community, and I'll speak a little bit more about each of those in just a moment. What we wanted to do before we get into the state presentations, which are at the heart of today's session, is to provide a little bit of context both for the webinar series overall and specifically for today's presentation. Next slide, please. So what we realize is that this is a very opportune time to focus on children in foster care. There's been landmark legislation over the recent years, including the Fostering Connections to Success and Increase in Adoptions Act of 2008, and the more recent Child and Family Services Improvement and Innovations Act of 2011. These acts addressed a number of issues of import to the foster care population, including the use of psychotropic medications, which the federal government recognized as a particular concern, as evidenced by landmark, what I call landmark and benchmark tri-agency communication. This letter came out in the fall of 2011 from the administrators of SAMHSA, CMS, and ACF, the 3 agencies with responsibility both for the payment of and oversight of services to children in foster care. And what these agencies recognized is that psychotropic medication use was cause for concern. There have been several national headlines, very unfortunate headlines related to children in foster care and their use of psychotropic medications. And the federal agencies took that opportunity to focus attention on the issue and then to bring resources to bear, technical assistance and otherwise, to states to help them increase the safety and appropriateness of the use of psychotropic medications among this population. Next slide, please. So here at the Center for Healthcare Strategies, we've recently completed a national analysis of Medicaid claims data. And within that, we conducted special analyses related to the foster care population with regard both to overall behavioral health service use and psychotropic medication use specifically. What we saw in that is that as it relates to behavioral health service use, children in foster care accounted for 3% of the child Medicaid population, 15% of those who use behavioral health services, and 30%, almost 30% of those dollars that were attributable to behavioral health service use. So we would certainly expect that a subset of children in foster care would have higher rates of behavioral health service need, but the rates at which this multiplies their representation in the population, and certainly the rate at which the dollars are attributable to this population, should be cause for at least attention, if not intervention, if we determine that the rates of use are inappropriate or the services that are being provided are not appropriate to the needs of the children. Next slide, please. So as it relates to children in foster care and psychotropic medication, we were particularly concerned about the rates of use as a specific class of behavioral health service. So we saw that children in foster care were more likely to be prescribed psychotropic medication, particularly if we looked at them in contrast to children in TANF. We would expect that children who are eligible for Medicaid by virtue of their SSI or disabled status would likely, some set of those children would have behavioral health service use issues related to those disabilities, and so we would anticipate that might be an increased rate of use, but the rate of use for children in foster care is not necessarily tied to a specific diagnosis that is the cause for their involvement in the Medicaid program or their eligibility for Medicaid. Secondly, we saw that they were more likely to receive multiple psychotropic medications, with 20% of those children receiving 3 or more psychotropic medications and 40% receiving 2 or more. While we recognize, again, that 2 or more may at times be appropriate given tapering and changing of medication, we're certainly concerned that 1/5 of these children actually receive 3 or more psychotropic medications. And then finally, there's a particular concern around the use of antipsychotic medications for children, and specifically children in foster care, because as the 2 earlier points recognize, they're more likely to be on these medications at all. And so the rate of use of antipsychotics among children in foster care who were receiving any psychotropic medication was 42%, both for children in foster care and children eligible for Medicaid by virtue of SSI or disabled status, versus just under 20% for children who are eligible for Medicaid by virtue of their TANF status. So next slide, please. So what are states doing? What we see is quite a bit of effort on the parts of the states to address the needs, and particularly behavioral health needs, of children in foster care. The Medicaid analysis that these data come from told us a lot of things. One of those in particular is that for this population of children, their service use and expenditures are driven primarily by their behavioral health service use, not by their physical health service use. Certainly they have what we tend to see in most pediatric populations. There's asthma as one of the primary physical health service primary conditions that are driving some of the physical health use. But certainly the behavioral health service use and dollars are by far the drivers for this population. And so what we're seeing among the states are several efforts to try to address the needs of the population. First and foremost, collaboration among Medicaid, child welfare, and behavioral health agencies. The Psychotropic Medication Quality Improvement Collaborative that I mentioned required that constellation of state agencies to come together in each of the participating states in order for them to be included in the initiative. Specialized care management approaches is another attempt on the part of states to try to, number one, identify the needs of the population, and secondarily to address them, and to develop a provider and system approaches that were tailored to and are tailored to the needs and the unique needs of this population. Some states are approaching this through a managed care carve-out or specialty managed care plans. One thing to always be to consider in the development of those types of approaches, we know that based on my most recent conversation, Brian Samuels educated me and let me know that 51% of children in foster care actually go back home. So while it's not the vast majority of children, there's a significant portion of those children who do go back home and who are no longer in the foster care system. And so if states are thinking about this approach, it needs to be one that ensures continuity of care regardless of foster care status. States like Tennessee have specialty provider networks. They have a best practice network there where there are providers that actually receive an enhanced rate to serve as a primary care provider for this population of children and to oversee care across systems for that population. And then finally, we know that Fostering Connections required oversight of medication, and then the most recent legislation in 2011 required and made explicit that the psychotropic medications were a particular class of medicine that needed to be overseen and monitored. And so special protocol for that is actually required, and states are attempting to respond to that requirement. So the 2 state initiatives that we wanted to very briefly touch on as we try to support states in their efforts to move forward with this population are listed on the next slide. The Quality Improvement Collaborative that I mentioned is funded by the Annie E. Casey Foundation. There are 6 states that include child welfare, Medicaid, and behavioral health across the 6 states. The 3-year initiative is really helping to support the efforts across those agencies to ensure that there's data that can be attended to and monitored and used to improve the quality of care and outcomes of care for children involved in the child welfare system and foster care in particular as it relates to psychotropic medication. One of the things that these states came together and did was to actually put forward a set of common measures that all 6 states agreed to collect and report to be able to demonstrate the impact of the work that they're doing on this issue of psychotropic medication use among the foster care population. And those measures are actually going to be the subject of our next call for this group. So look forward to receiving the invitation for that. And then finally, we received support from SAMHSA and ACF to make sure that the technical assistance resources that are being developed under the Quality Improvement Collaborative can be shared with states more broadly. And so many of you on the call today are actually part of the virtual learning community, and by now have begun to receive the monthly technical assistance e-newsletter. Today we're participating in the first of the bi-monthly webinars, and you also have access to the SharePoint Resource Center. So one of the things that's in that resource center is a scan of state-informed consent policies related to the use of psychotropic medications for children in foster care. Several of the states in the Psychotropic Medication Initiative are targeting their agency consent process as a part of the work they're undertaking through the collaborative. And we also always want to help the states that we're working with avoid recreating the wheel. So when we support their efforts, one of the ways that we do that is to first look and see what other states are doing that seems to work well for children and families, and bring that to their thinking as they determine what's most appropriate in their own unique environment. So at this point, I'm going to turn it over to David Bricklin-Small, who conducted the scan that set the context for today's session. David?
Thank you, Kamala. Stepping back, informed consent is obviously essential when it comes to the prescribing of medications in general and for psychotropic medications in particular. Being actively aware of the impact and possible side effect of medications is a necessary component of patient and guardians' participation in medical decision-making. For a number of states, the state itself plays a direct role in the informed consent process, often serving as guardians to the youth. In the context of the presentations we will hear today, some states have policies in place where a secondary review of a physician's prescription of psychotropic medication takes place, and we call these agency consent models. I'll describe these in greater detail in a moment. States vary considerably in how they define and operationalize informed consent processes for psychotropic medications, and while many states have informed consent policies in place, there are a number that do not. So when looking at informed consent policies, we see they vary along a number of dimensions, and this comes from our scan of state-informed consent policies for psychotropic medications for children and youth in foster care. So for example, consenting entity may vary. So who provides the actual consent for the medication? Is it the biological parent, the state-appointed guardian? What conditions dictate that? Similarly, is there a consent review entity, which speaks to the topic at hand today? Is there some secondary process by which the prescription of a medication is reviewed? What is the length of informed consent? How long will a consent last, and when does it need to be reobtained? What are the consent elements that are needed for approval? So do they need to document the dosage level, the child's diagnosis, residential status, or other topics? Similarly, a number of consent policies require that information, as you would think with an informed part of the informed consent, be provided to the patient or the guardian. Policies also vary along whether or not youth consent or assent is part of the process. At what age is consent required, for example? And finally, there are instances where states are able to prescribe without consent, and those vary across states. As noted, some states have policies in place where this secondary review of a physician's prescription of psychotropic medication takes place. As noted, we call these agency consent models. As we'll hear today, states can set up these agency consent processes in a number of different ways. For example, in what we are calling a decentralized consent model, review may be done by multiple reviewers, possibly on a regional basis. So New Jersey's agency consent model, which we'll hear about first, is most similar to this. In a centralized internal consent model, a state may have some unit located in child welfare, for example, that reviews all prescriptions of psychotropic medications for children and youth in foster care. Connecticut's agency consent model is most like this. Finally, in a centralized external consent model, a state may contract with an external entity, such as an academic medical center, to perform the prescription reviews, as is the case in Illinois. We will now hear from representatives from New Jersey, Connecticut, and Illinois as they describe their agency consent models that they use. First, we'll hear from New Jersey, and Mary Byrne, who is the Chief Child and Adolescent Psychiatrist for the New Jersey Department of Child and Families, providing consultation to the Division of Child Protection and Permanency and the Children's System of Care through the Office of Child and Family Health. In addition to providing direct consultation and education to this group, Child Health Program, and community providers regarding the mental health needs and treatments for children in child protective services, Dr. Byrne has been instrumental in the development and implementation and modification of the psychotropic medication policy and in the development of a trauma-based mental health training and screening initiative for child protection workers. Deborah Lancaster will be joining her, and she is the Director of the Office of Child and Family Health in the Department of Children and Families. As part of the leadership team within the New Jersey Department of Children and Families, her responsibilities include implementing a coordinated health care plan for children in the state's foster care system that ensures access to timely and appropriate health care, inclusive of both physical and mental behavioral health. Her office is also responsible for the development and implementation of psychotropic medication policy and establishing a plan for mental health screening for children who come to the attention of New Jersey's child welfare system. We will then hear from Dr. Leslie Siegel, who is Chief of Psychiatry for the Department of Children and Families from Connecticut. She is a board-certified child adolescent psychiatrist who has practiced in the public sector for the past 25 years. Dr. Siegel is Medical Director, Training Director of Riverview Hospital for Children and Youth from 1995 to 2006, and since then has been working mostly on the child welfare side of Connecticut's multi-mandate child welfare agency national committee memberships, including the AACAP's Foster Care and Adoption Committee and the NCINQ Foster Care Panel. Finally, we'll hear from Dr. Michael Naylor from Illinois, who is the Director of the Behavioral Health and Welfare Program, a program formed by contract between the Illinois Department of Children and Family Services and the University of Illinois at Chicago to address the mental health needs of the most severely disturbed state wards. He directs the UIC Clinical Services in Psychopharmacology program and consults with the DCFS Psychotropic Medication Consent Line regarding psychotropic medication consents for youth in state custody. In this capacity, the CSP provides an independent review of all psychotropic medication consent requests for foster care. I will now turn the announcement over to Dr. Byrne and Deborah Lancaster. Please go ahead, New Jersey. Thank you.
Hi, good afternoon. Next slide. So we just thought we'd start with some context for the state of New Jersey. We are a state-administered child welfare system that has experienced significant reductions in numbers in terms of children who are in foster care or in at-home placement. Between 2004 and 2011, we've experienced a 44% safe reduction in children in out-of-home care as part of our overall reform efforts. All children in out-of-home care are enrolled in a New Jersey Medicaid program. We have a number of Medicaid managed care HMO products that to choose from. And New Jersey has a relatively mature children's behavioral health system that we call the Children's System of Care. Next slide, please. A unique feature in New Jersey's child welfare system is our child health unit-based model of healthcare coordination. We have baccalaureate-prepared nurses co-located in each of our 47 child welfare offices across the state of New Jersey. Every child in out-of-home placement is assigned to a child health unit nurse, and their caseload each nurse has no more than 50 children on her caseload. Their responsibilities include ensuring that children in out-of-home placement receive comprehensive medical exams as they come into care, or within 30 days of coming into care, rather, that they are up to date on immunizations and child visits and dental care and any kind of specialty follow-up care that they may need. They also do a number of nursing interventions directly with our foster families. We call them resource families here in New Jersey. They disseminate the health passport that they create for the child, which includes a health plan for each child in at-home place and an individualized health plan. They do home visits to the resource parents or with the resource parents and the child, and do a number of screenings there as well, including mental health screening. They are also charged with ensuring whether a child is diabetic and taking insulin, or whether they have a psychiatric illness and may need a psychotropic medication as part of their treatment. They're responsible for knowing what those medications are and the prescriber and a number of other details behind those. So they're responsible with managing that. And it's important to keep that resource in mind because it did influence the direction we went in terms of developing our psychotropic medication policy and how we think about consent. In addition to the child health units, New Jersey is fortunate to have, and Dr. Burns obviously with us here today, a full-time child adolescent psychiatrist dedicated to child welfare and the department as a whole. And we also enjoy the benefit of having a full-time pediatrician and a neuropsychologist, all of whom do a number of things, but include case consultation when the local office staff or the nurses have questions, or quite frankly, when a physician or a treating psychiatrist may have questions. They're often the go-to people to team on a case. Next slide, please. So in terms of really grounding where New Jersey was going to go with our psychotropic medications overall and how we were going to think about consent, I think as David mentioned earlier, there's a number of, each of the states on the call has a different approach, slightly different approach, or maybe a radically different approach. We, I guess, call our model or refer to it as decentralized, and I think part of what influenced that was the resources we have in New Jersey. We did things like, we reviewed the children on psychotropic medications, and we continue to do that, and note that virtually all of them are prescribed by a child adolescent psychiatrist. What else? So 60% of our children return home. That was another factor, and I believe Kamala gave the national statistics on that. So many of our children do return home, and when they are in our custody, parents have rights to decision-making. So there were a number of factors that went into kind of us thinking about not having a centralized unit to oversee prescribing, and or having nor do we have a second opinion program in place. Rather, we have Dr. Byrne, who provides case consultation as needed and a relatively and an open door policy, so that anyone at any point in time can pick up the phone and request a consultation. But I think the overall thing that we kept in mind was our case practice model. The case practice model really has the parents as central to decision-making in children's lives. Again, many of them go home, and that's by and large part what we want to see. And so we are trying to engage families in this healthcare decision-making about their children. Next slide, please.
So in going forward with the way that we decided to approach developing our policy, we reviewed and this started in late 2008. We had a bare bones policy before that, but we really wanted a more in-depth policy about psychotropic medication. So we reviewed the ACAP and the American Academy of Pediatrics and Child Welfare League of America guidelines and the position papers. We reviewed other states' policies. Not surprisingly, they included Connecticut, Florida, Illinois, Tennessee, and Texas. And I actually spoke to both Dr. Naylor and Dr. Balanci about convenient, and the then medical director from Connecticut. And after we got a sense of what the variety of policies that were available were, and what kinds of components, we convened an internal work group that included our Office of Licensing, our Division of Child Protection and Permanency, our Children's System of Care representatives, and representatives from our adoption and resources and contracting groups. Next slide, please. And we developed a policy that has these components, that we require a psychiatric evaluation before medication is prescribed. We have specified who the authorized prescribers are. We require a treatment plan and informed consent, and then we also have some medication guidelines within the policy. And we require as well, we include as well some safety monitoring guidelines and prescribing parameters just as guidelines for the field. Next slide, please. So in terms of process, after we had the draft policy and felt that we were comfortable with the way that it represented our approach to medication management for kids in out-of-home care, we convened a psychotropic medication advisory group of people in the community, stakeholders, psychiatrists, psychologists, representatives of different agencies, pediatricians, a whole group of people to come together and look with us at the policy and kind of troubleshoot it. What did they see would be some of the flaws in our plan? What did they see were some of the strengths? How could we work around it? And also, honestly, to ask them to be kind of our ambassadors as we began unfolding it. So after their input was reviewed and incorporated, it was issued in January, signed by the commissioner and issued in January of 2010. We do have an updated revision that came out in May of 2011. Next slide, please. So internally, we felt it was really important to talk with the child, because it's a decentralized process, we knew that we needed to address with our child welfare staff and supervisory personnel and leadership to have a basic understanding about psychiatric illness. Like, what is psychiatric illness? That it's biologically based, that these are real things, not just problem behaviors, and to begin to get a sense of the role of medication in psychotropic treatment as part of all of the different interventions we can make for kids. So we had a series of workshops with the leadership in which we would talk about that and kind of what are the major classes of medications, what are the indications for the different medications, what are the risks and benefits of the different medications, questions to ask of providers, and then we held some more in-depth workshops with our child health unit nurses to help them understand in greater depth, because our nurses have come from a variety of backgrounds. Some have been NICU nurses, some have been emergency room nurses, so we wanted to bring them up to speed for what to think about with psychiatric illness and medication. Next slide, please. After we had done that internally, we also presented it to the mental health community. We went to several individual agencies, to the Mental Health Association, and then we had a provider forum where we invited people who were serving our youngsters, and really anyone who wanted to come, to a general open house in which we presented our policy and took some questions and answers and got an understanding of how it was working for them. And it really gave us an opportunity to meet face-to-face with some of the providers that we had not yet met. Because, again, we're not a geographically large state, but we are a highly populous state, so it gave us a chance to really meet some of the people who are providing. We went to some grand rounds for pediatrics, and I've had the opportunity to attend on-site some meetings with providers, both as part of treatment team meetings, but also just as a, hi, we know this is a change in the way you've been working with us around policy, this is what we're asking for, and to try and help them figure out how to work better with us and help us work better with them. Next slide, please. So the basic principles of our informed consent policy are that medical treatment for children who are in child protection and permanency custody requires consent, and it may be either for routine or non-routine care. Our resource parents are allowed to consent to routine care, so they can consent to antibiotics and things like that if there's an urgent need. Psychotropic medication, however, is non-routine care and requires specific written consent. The case practice model requires that the parents of a child, biological parents, that they have an important role in the child's ongoing care, and so we require their consent whenever possible. Next slide, please. So the child protection staff first seeks consent from the parents, but as you guys who are working in child welfare know that sometimes parents are not available. They may not literally be available. We can't find them. But sometimes the parental rights have been terminated, and sometimes there's a situation in which the court has delegated that authority directly to our Child Protection and Permanency Agency. In that case, our local office manager, and there are 47 local offices in the state, as Deb said earlier, have the right and the responsibility of consenting to medication and psychotropic medication for these kids. Next slide, please. So the child protection staff and the child health unit nurses work with the provider to gather all relevant healthcare information that will help the child's parent or the local office manager make the best decision for this youngster. So they will review the medical history, the current status, what the provider has provided in terms of a psychiatric evaluation, what the recommendations are for medication, and then provide that either to the parents or, and if it's the parents, I mean, they could be right there, but if it's this more complex process. And then the child health unit nurses are available to answer general questions, but not specific about the individual use. Next slide, please. In some instances, there may be a concern about consenting to the medication, for example, a very young child, or when the child is on multiple medications or has had a very difficult presentation and people are concerned about the recommended medication, if it's off-label for this diagnosis. Whatever it is, in those specific instances, or frankly at any time, a local office manager may contact me for a review of the case and with questions about consenting. So what we may do is have a conference call with the treating professional. We may have a treatment team meeting. I may even be able to attend a treatment team meeting in order to discuss what the recommendations are, what the questions might be, and whether or not there are alternatives that might be considered. Next slide, please. So I think that in general, and I know I'm speeding through this, but I'm a little worried about time, we feel as though we've been able to develop a policy that reflects New Jersey's values about decentralized and family-focused psychotropic medication policy. If most of our kids go home and most of our kids are treated in the community in which they grew up, then we want their parents and the people who will continue to be caring for them to have been part of the decision-making about medications. So the child health unit nurses do, though, report and track psychotropic medication utilization and policy compliance. So they both help care for they both help monitor the child's health throughout the time, but then quarterly they make reports to the central office so that we can review all youngsters, not just those for whom I've been consulted, but all the kids. And then what we do is we review them both for compliance with policy indicators, like whether or not there's a psychiatric evaluation and a treatment plan, whether or not the medications are appropriate for the diagnosis, what's the age of the youngster. We look at all of that. And then we also look at the rate of informed consents, and now we're looking at rates of current informed consents in the record. And then we do a quarterly quality assurance review of specific at-risk cohorts. So the littlest kids, those who are under 6 years old, kids on more than 3 medications, kids who are on medications for diagnoses that are not approved diagnoses. Next slide, please. And then I think our challenges going forward, I mean, we have ongoing challenges with implementation. Obviously, with a decentralized process and turnover in our providers and in our child protection and permanency staff, there are always new people who need to be brought on board to understand how our policy works. But I think in general it's been going well. What we're looking at now is looking at developing and integrating an assent process into our current informed consent policy and practice. That has not been part of our formal policy up until now, and we've been talking with our adolescent subgroup about how to make that work better. I should say, too, our other challenge right now is that we've also assumed greater responsibility for young people 18 to 21, and I think figuring out how to help them provide consent when they come of age is another issue that we're working on. So that's the brief heads up on the New Jersey policy. Do we have time for questions, David?
Yes, thank you, Dr. Byrne and Deborah. That was very informative. We have time for a question. As a reminder, please submit questions via the Q&A link that is located at the top on the floating bar. Please, you are welcome to submit questions throughout any of the presentations, and we'll hold them till the next break. We do have a question for New Jersey, and the questioner also mentions that it may be appropriate for the other presenters as well. But does the review ever include referral out to non-pharmacological therapies? So will a result of a review that you may do, Dr. Byrne, for example, with a child welfare worker or a parent or a nurse, will those ever result in non-pharmacological treatment rather than psychotropic medications?
Yes, that's a very good question. Our policy requires that youngsters are engaged in non-pharmacological therapy when they're also involved with psychopharmacology. So that's actually one of the reviews that we do quarterly. However, if the questioner is asking when I'm consulted about it, yeah, we always look at whether or not they're making adequate progress. So one of the things we might think about, if a youngster is being prescribed a medication and it seems as though they keep ramping up that medication, but they're not getting better, we'll often look at whether or not they're getting trauma-specific therapy, for example, if they're looking at more and more medication to control therapy. So, yeah, we look at lifestyle, we look at appropriateness of psychotherapeutic intervention, and whether or not they're in the right place. That's all part of what we consider in that consultation, but we also require it in our policy.
Great. Thank you, Dr. Byrne. In the interest of time, we're going to move forward with Dr. Leslie Siegel from Connecticut. And like I said, please feel free to submit questions via the floating toolbar at the top, and we will get to those afterwards. So, Dr. Siegel, please go ahead. Thank you.
Thank you, and good afternoon, everyone. Today I will be presenting Connecticut's model for consent for psychotropic medication. Next slide, please. Connecticut is a multi-mandate agency. The Department of Children and Families is responsible for child welfare as well as behavioral health, juvenile justice, education, and prevention. And I think we are only one of 3 states that have these multi-mandates. Rhode Island and Delaware, I think, have similar mandates. Next slide, please. So our process began in about 1999 when a new child psychiatrist became medical director and set up a psychotropic medication advisory committee, PMAC, which has met monthly since then, so the past 14 years. And the purpose of the committee was to look at what would be the best practice for informed consent for policies regarding medication with foster children, and evaluation and treatment, and all aspects of evidence-informed care. The advisory committee included private and public APRN, child psychiatrists, pharmacists, pediatricians, as well as Medicaid agency representatives. When Dr. Levin set up that statewide advisory committee, she also started consulting other states around what they were doing, and foremost in her consultation was with Dr. Mike Naylor, since they were working together at the time on the ACAP practice standards for prescribing in foster care population. Next slide, please. So what happened in Connecticut is that there were a group of legislators that first thought about passing a law or proposed a law where the legislators would give the informed consent for medication. And hearing that, Dr. Levin wrote her own legislation with her legislative assistant asking that the Department of Children and Families be the ones to provide the informed consent. And this law was passed in 2004 with the idea that we would establish a partnership with University of Connecticut, similar to the partnership between the Child Welfare Agency in Illinois and the University of Illinois. Next slide, please. So while the initial proposal was to have a partnership and an RFP was written, I think because of the expense, and I wasn't involved in the decision making at the time, but because of the expense, and also because we already had our own multi-mandate. We already had a behavioral health unit within our child welfare agency. We had child psychiatrists working at the state. The DCF ran the Children's Hospital, Children's Psychiatric Hospital, and also ran a juvenile training school for committed youth, several residential programs, and we had our own school district. We decided that maybe it made the most sense in our state to have a division, a unit within the state agency for consultations and consent. We thought that the internal model would possibly be more cost-effective, since we only would need the dedicated positions and then use other existing state resources, and that the staff in the internal unit could be used not only for consent but for state-specific consultations. Next slide, please. So this is the original centralized medication consent unit that went into action in 2007. At that time, Dr. Janet Williams was chief of psychiatry, and we had 3 child psychiatrists who consulted to different parts of the state, 3 advanced practice nurses, and 2 support staff. So the purpose of this unit was to provide informed consent for the children committed to the state, and also to provide statewide consultations. After this original design, we also added a trauma specialist, a psychologist, to help with the statewide consultations. Next slide, please. So we envisioned, as part of the stakeholders in the informed consent process, the child or youth, the child welfare worker, the foster family, the primary care provider, and the centralized medication consent unit that would be making the final decision. Next slide, please. So when the original policies and procedures were set up for the informed consent, we also had policies for assent, and our policy was that patient assent was required for all youth ages 14 and up. But we also thought that it was best practice for children age 9 and up to be informed about what they were taking, and that it would be explained by the prescriber in a developmentally appropriate way. The guardian consent, and our unit provided the guardian consent for kids that were committed to the department under abuse or neglect, duly committed, delinquent, and under abuse and neglect, those children that had termination of parental rights, and also for children that were committed by a probate court as a mental health commitment. So our unit provided consent in those circumstances. We do not provide consent when there's an order of temporary custody. Next slide, please. The process of consent involves a shared decision-making process. And we found that shared decision-making was associated with better outcomes, partly due to, this is actually what the research on shared decision-making shows, that it's associated with better outcomes, partly due to increased involvement by the youth, and then they'll be more likely, when they're involved, they're more likely to comply with whatever was prescribed. The components include agreement with what is being prescribed, knowledge about side effects and necessary monitoring, and also alternatives to medication. And these principles in shared decision-making were very similar to the team decision-making principles, which the child welfare staff in Connecticut, and I think many other states, are currently being trained on. Next slide, please. So this slide shows really the nuts and bolts of our consent procedure. So a prescriber completes the state consent form, which is called the 465, and emails or faxes it to the centralized medication consent unit. Then the centralized medication unit, child psychiatrist or APRN, reviews the information, checks SACWIS, the electronic database, for past prescribing information and past medication that the child's been on, and also past treatment they've been in. If after the review the request is considered appropriate, consent is given and emailed and faxed back to the provider. The CMCU then enters this information in SACWIS and emails the worker, the regional nurse, and the regional clinical manager details of the consent. The provider getting the fax back from us fills the prescription, and then the process would start all over again if new medication is requested. Our consent is prescriber specific. So if a child moves from one home to another or one setting to another, we ask that the new prescriber goes over with the child as a family what the medication is, why they're prescribing it, and what the risks and benefits are, just like anyone would do if a child was in their biological family and changed prescribers. The consent, the maximum length of time is for 1 year, and it needs to be renewed every year. Next slide, please. This is the form that we use, and you can see there's a lot of information on the form. We have where the child is currently living, the reason for the request, is it a dosage adjustment, a new medication, or a yearly renewal, or just to continue current medication if someone is being hospitalized. We'd ask that the hospital request to continue the current medication before making any further medication changes, and that's one way that we can check to make sure that what they think they're on is what we have in our records. They list the diagnosis, the clinical reasons for the request, the dose that they're looking for, and the target symptoms, a cross-taper plan if it's recommended. And then what we have, we have monitoring guidelines on our website, tests that are supposed to be done before medication is started or while someone is on a medication, or medication specific. So we have some of the things that we're asking for, of course, would be like lithium levels or Depakote levels or EKG if somebody's going to be started on an antidepressant or stimulant, perhaps if we don't have knowledge of a cardiac history. Height, weight, and BMI percentage has been very important given what we know about weight gain in this population. And I think you'll, on the form, what we do is we let providers know that if the form is incomplete, it may take longer for the consent to be given. But usually we turn these around in about 24 hours if it's a working day, 24 business hours. Next slide, please. So we base our consent decisions based on we verify the legal status. The form has to be relatively complete and the baseline monitoring done. We want to make sure the medications fit the diagnosis. Next slide, please. The Psychotropic Medication Advisory Committee that I previously described we review medications, review the evidence, the literature for medications working for children and adolescents. So we have a approved list of medications, although we also occasionally will approve medications that weren't on the list if the prescriber gives a reasonable explanation. We have maximum doses for children and adolescents. And again, every now and then we'll go above the maximum if the prescriber has a legitimate explanation. We look at the overall number of psych meds that are being prescribed, and this is where, if we see somebody's been on a medication for the last year and doesn't appear to have benefited, it will, I think we can become more active in encouraging prescriber to consider stopping that medication. We generally approve only one antipsychotic at a time unless there's a cross paper. And this has been a big, I think, change in the last 5 years where in Connecticut the prescribing community has become more aware of the fact that there's no evidence for two antipsychotics at once in most situations. Next slide. So other factors informing our decision, the past psychiatric history that's available in our SACWIS system, the child setting, our history with the prescriber, and we get a sense over time of who may be more of an outlier in prescribing versus who may be fairly conservative. And I think because our unit's been in existence since 2007, we do have a sense of a lot of the prescribers, although Connecticut, because we have 3 training programs for child psychiatrists and we border states that also have training programs, I think we have about at least 100 prescribers for children and adolescents. So that's a lot of education on the part of the CMCU to outreach to the prescribers. We're also looking at other treatments received, especially trauma-informed modalities. And this is especially true for young children. If someone is trying to start someone on the first medication and we'll check to make sure that they've had a good evaluation, they've been in treatment, in trauma treatment or in another kind of family-based treatment first before approving a psychotropic medication. Our overarching goal is to try to have our children on the least number of medications for the least amount of time, and so we may be nudging our prescribers in that direction when we're speaking with them. And so the other thing I should mention is that we don't turn anyone down without talking with them first. So if someone may get a consent may be approved, just get a fax back. But if there's a question or we're thinking that we're likely not to approve what they're asking for, we always call them. Next slide, please. So we have since we've been in operation since 2007, we've been able to see some changes in some trends over time. And in the beginning of when our unit was first operating, we were more likely to give consent if the request was within a core guideline, so it was approved med and an approved dose. So in the last 2 years, we've had more dialogue with prescribers, more discussion of trauma-informed treatment approaches, and that's also because we, Department of Children and Families, has had a couple of grants to infuse trauma-focused CBT around the state and other trauma-informed type of care around the state. So we know that they now exist where they maybe didn't in 2007. So we're talking with the prescribers about what else is being done for this child. And so what we found is that in the last couple of years, we've been modifying the consents that have been received up to 29% of the time. Whereas in the beginning, it was more, yes, no, maybe a 5% modification. Next slide, please. And so this is just a sample from 2012 of the number of requests that received and how many were approved, denied, and modified. And you can see that our denial rate is fairly constant between 1% to 4%. So we don't outright deny that many of the requests. But the modification in this past year was between 10 and 25%, and then when we modify a request, we may, encourage someone to stop another medication that they've been on for a long time that doesn't seem to be helping. We may encourage them to try a lower dose. We may be talking to them about if we notice the BMI percentage is high, what other things they're doing for weight control, and could they consider a medication that is less likely to cause an increase in weight. So those are the type of things that we code as modified. Next slide, please. And then I think we maintain a website that's readily available. All you have to do is Google Connecticut DCF, and you get to our home page, and it's right on the front of our home page, where we have information about meds, the prescribing doses, monitoring protocols, lots of links to information for workers, for families, and I think links to the Illinois site, other resources, plus the minutes from the monthly meeting that I described earlier. Next slide, please. And this is just the what's on our website. As you can see, lots of educational material and our monitoring procedures. So I encourage you to, as I said, Google Connecticut DCF and you'll find it. So the pros of a centralized process, and I think New Jersey talked about that they have a decentralized process, which I didn't go into our history, but that was the way we did it before we began the CMCU. We have a standardized system that is a quick turnaround. The providers are happy because before this they found that it took a long time to get consent back. Our medical team enters the note directly, so the medical information is accurate. And since we have all the history from 2007, we have a lot of past history on the kids in the foster care system that we can then make available to the providers. So they see us as a resource, and they like that. Next slide. The cons, I think the child welfare staff still feel disconnected from the process. The worker may have information from the foster family that is different from what the prescriber is told. And I don't think I mentioned how we often will, if there's a question, we call the worker, we call the foster family, we might call the PCP. So our quick turnaround is for the easy requests, but for sometimes the turnaround may take a week or two or even a month as we're gathering more information. But there's still a con is that the worker, the foster family may feel that they don't have the authority or access to question the prescriber. They may feel that they can alter or undo the official CMCU consent. We do a lot of education around how much we value their input and how we will rescind approvals, but still they do feel that way at times. And the patient assent process, we rely on the prescriber to document patient assents, and it's in our policies. I'm still never quite sure how much assent is really being obtained, and we know that many people experiencing the foster care world will say that as soon as someone turns 18, they will stop their meds, and I think that if we the assent is a big part of informing them about why they were on it, and having their buy-in will lead to a better outcome. Next slide, please. And I think also that the crisis of credibility between child welfare staff and child psychiatrists is real. And I do a lot of training in the area offices about that. I showed Diane Sawyer's 2020 segment with foster children describing their experiences on psychotropic meds. It's a pretty anti-med film. I don't know if people have seen it. You can get it on, it's readily available on YouTube. But when I talk about this, I also say that I've never met a child psychiatrist that went into the field who wasn't interested in helping children, but that we don't always have the best tools at our disposal. But in this training, I also talk about the importance of collaboration. and I try to push back on the feeling from workers that prescribers are just over-medicating the kids, and I talk about the importance of bringing prescribers, giving them all the information, which is what I find is a problem, that the prescribers don't know about the abuse and neglect history. They don't have the past psychiatric history. They're just trying to do the best they can with what they have in front of them. Next slide, please. So as I said, the next steps in our unit is we're trying to complete psychotropic med training for all caseworkers. We're training foster families. I just did it a couple weeks ago at our first foster family university. We're going to be developing our training in Spanish. We would love to be able to link trauma treatment data with the medication data. And right now we're also in the process of analyzing our data by race and ethnicity. Next slide, please. This is our consent data from 2012. So you can see that 23.1% of the kids is on the bottom right-hand corner. 23.1% of the kids in foster care were on psychotropic meds, and of the but 5 and under, 2% were on psychotropic meds. And we had a total of 3,037 kids committed in 2012. And that's a big change for Connecticut. I think New Jersey is talking about how they're changing as well. But when the unit started, there were about 6,000 kids that were committed to the state, and now there are 3,000. Next slide, please.
Great. Thank you, Dr. Siegel. That was very informative. We have time, like I said, for one question. And we've gotten a couple about the role of youth and families in particular. One question asks, how is shared decision-making with youth or families part of the consent process? I know you touched on it a little bit, but I think they're looking for a little more detail if you have it.
Well, as I said, our policies require patient assent. So the youth should be getting the information from their prescriber, but we don't document that in our system. And so I'm just having to believe, because it's our policy and because we do a lot of education, and also because it's the best practice for child psychiatrists to be going over this with their patients, that is happening. As far as the foster families, I just did the same training that I do for child welfare workers on psychotropic meds. I just did for the first group of foster families, and I plan on continuing to do that around the state. Because I think that we wrote a booklet for foster families about medication that's on our website, but I think that we need to include them more in the process and give them the same tools that we're giving everyone else about how to make sure that the kids in their homes are receiving quality care.
Great. Thank you. Thank you again. As a reminder, you can submit questions via the floating toolbar at the top, and we'll have one last opportunity for questions after Dr. Naylor's slides. Dr. Naylor, let me turn it over to you, please.
All right. Well, we have just seen the disadvantage of giving a talk after two really great presentations. I'm going to talk a little bit about the consent process for the state of Illinois for psychotropic medications. And I think, as David mentioned earlier, this is a somewhat different model in that this is a program contracted by a university. So it's an external reviewer on a centralized process. Next slide. Before we get into the talk, I wanted to give a little bit about the backdrop for all of this, and it actually describes some of the other programs that we have, or how they came about anyway. At one point, Illinois' child welfare system was the embarrassment of Illinois for sure, but when Clinton talks about how Illinois child welfare is the Bombay of America. We had a lot of press nationally that really was quite negative. And the care provided was so bad that DCFS was sued by the Department of Justice and the ACLU. And at the end, one of the things that I'm going to talk about are kind of like how-tos. And if your political career can withstand the challenge, one of the how-tos is to get sued and have a consent decree, because it really worked for us, and I think it worked for Connecticut as well. But the specific areas of problems were inadequate casework, chaotic and dangerous placements, and substandard mental health care. And the conclusion basically was that Illinois was violating the constitutional rights of kids. Next slide. And we'll go past this one just saying that it was referred to as a system of shame. Next slide. So this was settled in a consent decree. This was a very unusual consent decree in that both the defendants and the plaintiffs agreed on one person to provide, or not one person, but one entity to provide the consultation to improve the quality of mental health services. And so the Department of Children and Family Services and the ACLU agreed to have the University of Illinois at Chicago Department of Psychiatry serve as the experts for this system reform. And along those lines, there were several programs that were set up to improve mental health services. One is the Comprehensive Assessment and Response Training System, which is an inpatient service that serves probably the most challenging kids in the state. In order to get referred, they've had to have had multiple placement disruptions, multiple psychiatric hospitalizations. So by the time they get to us, it's 4 or 5 residential facilities, 4 or 5 foster home placements, and maybe 10 psychiatric hospitalizations. And they've had to have been aggressive. And so for this population, we provide a lot of technical assistance and consultation to residential treatment facilities where most of these kids are coming from. Part of that was a mental health policy program that reviews the functioning of residential and psychiatric facilities. Another one was a applied services research and evaluation program that looked at quality improvement measures and implementing them statewide. And then the fourth component was the clinical services and psychopharmacology, which I'll describe. So next slide. About this time, you know, nothing like a lawsuit to focus your attention, DCFS recognized the need for quality assurance regarding the use of psychotropic medications, and we were contracted with in 1992 to provide independent medication reviews. The next slide. The basis of these reviews is DCFS Rule 325, which recently underwent a revision. For those of you who can access this, these are hyperlinks, and maybe we'll have those hyperlinks active when we place it on the website. But the Rule 325 is called Administration of Psychotropic Medications for Children for whom DCFS is legally responsible. And the revised rule actually includes our guidelines for the utilization of psychotropic medications for children in foster care. These guidelines were set up as a result of an expert panel that met for 2 days in June 2006, where we had external consultants, some from UCLA, one from let's see, Johns Hopkins, and then our own Mina Dalkin, and a variety of stakeholders from around the state. And as a result of that, came up with the guidelines for utilization. Next slide. So what is the challenge of Rule 325? First of all, it's to provide informed consent for these medications. Secondly, to provide safe and effective care that's delivered in a timely manner that protects the rights of foster children and provides longitudinal oversight. And this last point is an incredibly important point because, as was alluded to in the other talks, the longitudinal oversight and care of these kids is often lacking. Caseworker turnover is huge. In some places, it's 80% in a year. And kids go through a variety of different care providers, pediatricians, child psychiatrists, and the like, and especially if they've had multiple placement disruptions. Next slide. So Illinois addressed this by coming up with a two-part solution under the centralized DCFS psychotropic medication consent program. The first component is the centralized psychotropic medication consent line. That comes through the Department of Children and Family Services, and then the Clinical Services and Psychopharmacology, which was contracted through UIC. And we like to refer to that as informed and consent. So the Clinical Services and Psychopharmacology program is the informed part, and the DCFS component is the consent part. Next slide. So for DCFS, when I first came into the system, there were about 50,000 kids in care. Right now, there's 15,100 kids that DCFS is the legal guardian for. And now the program that I'm describing, the oversight and the consent exists only for those kids in temporary custody and those whose parents' parental rights have been terminated. And so we don't really get involved in ones where the parental rights have not been terminated. We do, however, offer second opinion consultations for foster kids after they've turned 18 and are felt to be capable of making their own decision. So we probably provide about 200 consultations a year to 18-year-old foster kids who want to know about the validity of their medication regimen. And some of them were actually pretty scary. The kids were on the right track. We recently had a change in our guardian, but essentially the guardian is the parent of 15,100 kids. And their role is to provide medical, surgical, end-of-life decisions, and psychiatric care for these kids, consent for those services. And that's done, since one person really can't do 15,100 kids, there are authorized agents who are empowered by state law to provide the consent under the guidance of the guardian. Next slide. So the Clinical Services and Psychopharmacology consists of a child psychiatrist. It's about 1.0 FTE. Half of my time is covered, and 1/10 of 5 other child psychiatrists are covered. We have 2.5 psychiatric nurses, 6 research assistants. We have access to a programmer and a master's in public health to help with some of the research. The cost for this is about $1.2 million, and it is paid for out of the budget of the Department of Children and Family Services. Next slide. So the Clinical Services and Psychopharmacology actually provides a lot of different services. The first one really is to provide an independent medication review for all psychotropic medication requests for kids in DCFS custody. We're also charged with monitoring the utilization of psychotropic medications, notifying the guardian where we see problematic prescriber patterns. We have also provided education to foster families, and in fact just put together a website or a webinar which will be mandatory for training of caseworkers and soon will be modified for foster families. We talked to the foster care agencies, residential facilities, even psychiatric hospitals. So we have a fairly high profile from an education point of view in the state as well. Next slide. So this is the schematic of our consent process. So the prescribing clinician, or often this will be the placement like a psychiatric hospital, a nurse may fill that in, or a residential facility. They will fill out a form, and we'll show you that form in just a bit. Fax it to the UIC research team. And, you know, not too terribly long ago, faxing was really cutting-edge technology, and now it's sort of bearskin rugs and bone clubs technology. We're trying to get this so that all of the consents can be submitted directly online for a variety of reasons, not the least of which is the major cause for delays in consent are illegible forms and incompletely filled out forms. This then goes to the research team, who gets the additional information if needed to fill out the forms. It goes to the psychiatric nurse, who does the first clinical review. If questions arise, they can send it back then to get additional information from the prescribing clinician. It goes then to one of us consultants, all board certified, and then once we're done, it will go back to the UIC psychiatric nurse, who will then send it both to the authorized agent to provide the consent, and also to the research assistants to enter the data into the database. We get the inpatients done when they're uncomplicated, meaning diagnosis and symptoms match, the treatment is appropriate for that diagnosis and that symptom and those symptoms. There isn't any really crazy polypharmacy, and all of the information is complete. Inpatient requests tend to take about 4 hours, so we get them back on the same business day. The outpatient uncomplicated ones are done in about, it varies between 7 and 9 hours, so no later than the next business day typically. Complicated ones can slow it down, and complicated ones would be really complex polypharmacy requests, unusual kind of medication requests, and those get additional reviews. So we will often do a literature search, abstract the literature, and send them to the clinicians in terms of our response. Next slide. This is the form we use, CFS 431A. I won't go over this in any detail. It's on the website, and there's a link to the website later. Next slide. This is the information that we're getting, demographic data. Next slide. Clinical information, diagnosis, current medications, and this is not limited to psychotropic medications, but all medications. Laboratory requests, they will also then tell us what medication they're requesting, the dosage and the frequency, and the rationale for that. Next slide. So the type of medication request, they will indicate this when they're submitting the request. It can be for a brand new medication, for a medication renewal, for an increase in the medication dosage, and this form is also used to notify us of the administration of emergency medications. So Rule 325 requires not that the placements get consent for that. If it's an emergency, you can't wait around 30 or 45 minutes in order to get consent, but that within the next 5 business days, the unit will be notified of the administration of the medication, including the name of the medication, the dosage, the indication, the route of administration. And what we find is that is one of the most sensitive indicators of how well a program is doing. And so if we see a program that all of a sudden has a huge spike in the use of emergency medications, we're able to identify them and often able to get them some additional resources, whether that be through technical assistance or consultation. Medication range, the dosage, the consents, unless they're modified, are good for 180 days, and they are kid-specific, meaning that the consultation or that the consent will follow the kid to other placements. And then we will also want additional rationale for, say, polypharmacy and why they're wishing to prescribe a specific medication if it's not a first-line medication. Next slide.
Hi, Mike. I'm sorry to interrupt, but I just wanted to note that we have about 3 minutes or 4 minutes left for the presentation before wrap-up. I'm sorry to intervene, but just wanted to give you that heads up.
Our recommendations: approve, deny, or modify, and then we review the emergency medications. Next slide. This is a breakdown of, we don't have the rescinds. Most often, clinicians will rescind if questions are asked that kind of shed a light on prescribing practices that are somewhat problematic. Next slide. This is how many consents we're doing. We do about 14,000 consents a year and about 7,000 emergency medication notifications. Next slide. I'm going to go over these very quickly. There's a lot of oversight that's provided in this, including case-specific. So I can be asked, or typically it will be me, to provide independent medication reviews or even evaluations. We have a watch list for high-risk children. Next slide. We have system-wide, so we give monthly reports that talk about emergency medication use, rates of prescribing, rates of polypharmacy, rates of antipsychotic polypharmacy. We have a watch list for high-risk prescribers, and we are now getting Medicaid payment data. It's not up to date yet, but this will allow us to be 100% certain that medications are prescribed with consent. Next slide. These are the quarterly reports we were talking about. We also measure our own performance. Next slide. And these are our high-risk oversight measures: children under 4 on psychotropic medications, polypharmacy, co-pharmacy, typically of antipsychotics. And then we've identified kids that are at high risk due to multiple placement disruptions and polypharmacy. Next slide. All of this information goes back to the Office of the Guardian, but a multitude of other sources get back there, including administrative case reviews, the Guardian ad litem, Office of the Public Guardian, regional nurse, all of which feed back into our process, which allow us then to provide additional review of medication regimens. Next slide. We've been able to use this data for a variety of things. One, we were the first to report in 2001 of a dramatic increase in the rate of diagnosis of bipolar disorder. We were able to show the adoption of evidence-based use of SSRIs on the basis of our reviews. We've been monitoring the weight gain with second-generation antipsychotics, and I'm here to tell you that there is no such thing as a weight-neutral second-generation antipsychotic. And again, identification of high-risk preschoolers. Next page, next slide. So our program, the way it's set up, can assess statewide diagnostic patterns, monitor utilization of psychotropic meds, identify and monitor adverse effects, implement evidence-informed consent strategies, and assess the impact of changes in consent strategies on provider behaviors. Next slide. So the how-tos, I'm going to go over this real quickly, and maybe we'll have a couple minutes to talk about these. So if you're putting into place a consent process, the first thing is to have a clear policy in place regarding consent issues. Who provides the consent and how? And this varies from state to state. What is the purpose of the consent program? Is it for oversight? Is it for consent purposes? Is it regarding decreasing utilization or cost containment? And the type of review and the type of oversight will be dependent upon the purpose of the program. Next slide. Illicit partnership with and cooperation of professional organizations. I can't tell you how important that is. Too often the prescribers feel like they've been left out of the process, as do the foster parents, as do caseworkers. So stakeholders should all be involved in this. What I would say is implement the program in its entirety. There's a saying by Walmart about being nibbled to death by guppies. It does not decrease the pain involved of the oversight. No docs like oversight. And in fact, it actually prolongs the pain over time if you do it in bits and pieces. So plan it out initially, and I say implement the whole thing at once. And then the last thing is once it's in place, communicate with the providers. And I think that's it.
Great, thank you. Unfortunately, in the interest of time, we're not going to do any Q&A now, but what we've been doing is collecting the questions that people have submitted during the call, and we will produce an FAQ sheet for them. So we'll go back to the presenters and get their opinions on some of the questions that were raised. So just want to quickly highlight our last slide here, which is that CMS and AHRQ, the Agency for Healthcare Research and Quality, they funded 7 centers of excellence to develop quality measures for the pediatric population in Medicaid and CHIP. And a subset of those measures development activities are being led by a group called InSync. And if you'll notice the last bullet in the first column, care for children in foster care, the second column represents measure development concepts under that topic, and NCQA and its partners are seeking states that are willing to test any of the measures once they're ready to inform their understanding of the feasibility and utility of the measures. If any of the states on the call are interested in doing so, please note that when you complete the evaluation form and include your name and contact information. And so that gets me to the point that, indeed, we will have a survey that will pop up immediately at the close of this webinar, and we ask you to please complete it as it helps inform this webinar, but also how we do things moving forward. So that concludes our webinar. We want to once again thank Deborah Lancaster, Mary Byrne, Leslie Siegel, and Mike Taylor for their wonderful presentations. This was a really exemplary first webinar in a series that we are initiating, and so we hope that our participants have enjoyed it. And the webinar recording will be posted on our website in the next week or so, and we'll send out information on that, as well as, like I said, information about the Q&As. So thank you very much for your time, and we will be in touch. Take care.